It's
Unit.
just a function. Because you use the deformity.
I think we'll get started here. So.
Yeah. Maybe we should do that.
Our next speaker is Dr. Mohan,
Oh.
and his topic is Cauda Equina Syndrome, all that you need to know. Dr. Mohan is a physician with clinical interest in neurosurgical and spine-related disorders. Participated in multidisciplinary clinical and academic collaborations focused on advancing treatment strategies for complex neurological conditions. Dr. Mohan contributes to ongoing education and research initiatives within the neurosurgical and neurological communities. Dr. Mohan, welcome to the podium.
You guys must be wondering why old topic, Cauda Equina, is being talked about in a new setting. It's the syndrome remains the same and the language remains the same, but what is there in this litigious society wherein which everything is under the observation of the microscope by the lawyers? What are the best sentences to be used in the documentation process? And the situation, what happens is, here you have a patient who presents with Cauda equina with paraplegia, and say that the paraplegia does not improve over a period of time. He somehow contacts the lawyer, and the lawyer says, I'll get you the money. And the lawyer and the patient, they have an understanding, and they know that the neurosurgeon is one of the prestigious academic career wherein which the neurosurgeons may make money. So they say, okay, this is a cash cow, let's go after it and get the money for this. And patient wants the money, the lawyer wants the money. But you're the one who sat with the patient, who was very compassionate to the patient, took care of the patient, but you didn't use those words that was not recorded in the your what you call the history and physical or the progress note. They are basically doing the bench discussion when you were in the military, when you were holding the arms and fighting the war. They were not there. They are here analyzing what all you did in the war. So this is what I want to present to make sure that you guys have the language that has to be clearly documented so that you are protected in terms of litigious society. Is that a thing which we can, or we just have to go by this?
Yeah.
Yeah.
So, Cauda equina, as we all know, is typically including the nerve roots, anything below the conus, L1 to L5, and it also has got a sacral component, S1 to S5, and the coccygeal nerves. So all these are Cauda equina. But what is Cauda equina syndrome is, it's a compression of these roots giving rise to the malfunction of the motor system, sensory system, and the autonomic system, and the visceral system, which includes the bladder and the bowel. It's a clinical and a radiographic syndrome caused by compression of or the dysfunction of the lumbosacral plexus, typically below the conus, that is conus ending anywhere, as you know, from T12 to L2, you can have a conus. Most commonly, it's a massive central disc herniation at L4-5 or L5-1. And problem becomes much more complex, much more difficult when this disc herniates between L1-2 or L2-3, where sometimes the conus extends longer, and it is a situation wherein which when you open with an MRI, you have a tense cord, or the tense conus, or the tense dura, and you don't know whether it is the conus tumor, or an abscess at the conus, or whether it is something to do with just the disc, which is an extradural manifestation. And all these things, the way the patient presents is the duration of the severity of the compression giving rise to all the situations with ischemia of the central nervous, the peripheral nervous system here. So the bladder gets painless urinary retention, bowel will have constipation. We're not talking about the sexual situation when the patient is presenting in the ER, and the saddle anesthesia and the bilateral asymmetric weakness. That is very classical about the Cauda equina. And in the conus, it will be more symmetrical, and in the Cauda equina, it will be asymmetrical. In the conus, it will be more of a mixed lesion of an UMN and an LMN, but Cauda equina is an LMN syndrome. And severe back pain and bilateral sciatica. Now, it's very, very important to document in your record the PVR and the rectal tone and then the anal wink to make sure that the anal sphincter is intact. And the PVR less than 100 ml is considered as normal in a somewhere around like less than 50 years old, but there are, like up to 200 is acceptable, and if it is painless and retention, it is, the viscera is already taken the damage. This is the most classical thing that you have to know. This is the thing that is very important as far as litigations are concerned. What is Cauda equina suspect? What is Cauda equina incomplete? What is Cauda equina with retention? Now, Cauda equina, if you might get calls in the ER saying that, oh, doctor, there is a patient with a back pain and he's got severe back pain, not able to move, and probably Cauda equina, and then you feel like rushing to the ER. But the thing is, Cauda equina suspect that patients can mimic some of these symptoms. They don't lift their legs. They are basically there for a secondary gain. And you know that there are patients presenting with that kind of situation, and you also have clear patients who have problems. And that is Cauda equina incomplete. There is widening difficulty, but there is no classical retention of the urine. That is very important to have that, and they will have the rectal tone will be still preserved. Cauda equina with retention, which is a painless urinary retention more than 200 ml, is the situation when it presents along with the motor weakness. Is one thing, patient has already passed the time frame of helping him to come back to his normal. They may gain, but they may not gain also. So that's where the wordings should be very clear in your documentation. We do the MRI. You can even do it if there is no MRI availability. You can do a CT myelogram, put the Foley, get what's the PVR, and get usual pre-op labs to get ready for surgery. Now, when do we operate? If you ask any neurosurgeon, any orthopedic surgeon, oh, you got to do it very quickly. You got to do it as soon as possible, 24 hours, 48 hours, random numbers. Everybody thinks that you should do it within 48 hours, and that's been taught, and that's been followed, and we think that we're going to make a huge difference. This is very crucial, and I want to go more on this to make you understand when it should be done. Best timing, yes, as soon as possible. Depends. Is it Cauda equina incomplete or Cauda equina with retention? Cauda equina incomplete, where there is anal wink, there is not much of a saddle anesthesia, there is some perianal anesthesias, paresthesias, and your retention is not complete, then you can, doing surgery within 48 hours, definitely will improve the motor function, definitely probably with bladder training and all that, will get the bladder back. But Cauda equina presenting with retention is less likely to improve both the motor function and the bladder function. So we have to make sure just because the patient is presenting with back pain, presenting with saddle anesthesia, presenting with motor weakness, doesn't mean that it is just the disc. There's a possibility of a non-compressive etiology, which could be inflammatory, could be ischemic, neuropathy or toxic neuropathy, and decompression is not going to help those people. So you've got to be 100% sure that you're not dealing with a non-compressive lesion before taking the patient to the operating room. Medically prohibitive risks, like if the patient has cardiopulmonary issues, end-stage palliative care, established long-standing deficits, you're not going to do. Like a Cauda Equina sitting at home for 1 week, you're not going to do anything. Even if you rush to the operating room, you're not going to make his neurological status down. As I said, common levels are L4-5, L4-S1. Less often is L3-4 and L1-2. And then the L2-3, L1-2, conus overlaps and syndromes manifesting both ways is very likely. And you can have large disc herniation, massive stenosis, epidural abscesses, epidural hematoma. All these are possibilities. This is just to take it, it's for more of a medical student thing with conus and so one line viva, like oral exam is CES is a lower motor neuron polyradiculopathy, whereas the conus is more of a mixed UMN and LL. Rapid decompression is acceptable, especially if it's a compressive, like if you have an abscess or if stabilization is needed, you can consider stabilization. Usually an urgent laminectomy, discectomy, multi-level decompression instrumentation if there is instability or you created an instability. Best predictor for the Cauda Equina recovery, as I said, is the involvement of the visceral function, pre-op status and the timing of decompression. These are some of the other this is the wording that is very important. Okay, we have to say there is a possibility. First, we have to say that the goal of the surgery here is to decompress the nerve and preserve the maximum function. Do not say that we are going to cure you, and say that there is a need for reoperation if required, because as we go in for any of these herniated discs, first time we do is like we take the disc out. Whatever is come out completely we take out, and whatever pre-fragments are there we take. We don't dig the entire disc to do full fusions like interbody fusion. So there is once there is an annular tear, there is always a possibility that there is going to be a reherniation. And the second time the reherniation is there, you're not going to just take that disc out and then allow some more fragments to come back. So the second time is like, you literally have to take the entire disc out, do an interbody fusion, and fix the patient. So there is always a possibility in the consent. You have to say that there is a need for second surgery if required. And recovery of the lower limb paraparesis and all this may be a possibility, but it is an it's only a hope. It's not a promise. That's very important to say that. Because your MRI shows mechanical compression, non-surgical treatment is not going to help. That is very important to say, because when the guy says, can we do something other than surgery? No, you can't. So we got to tell them that the surgery is very important. And then consent phrasing. You have Cauda Equina Syndrome from a pressure on the lower spinal nerves. We recommend urgent decompression, prevent further nerve damage. Whatever has happened, we don't know whether you're going to get it or not, but further damage I can prevent it. And to give you the best chance of recovering the bladder and bowel and the leg function. There is no guarantee of recovery. Please document this. This is very important. So this is again, I'm going on the documentation checklist, tying all this. One side algorithm is red flags, saddle, anesthesia, bladder, bilateral sciatica, exam plus PVR, and the MRI stat or CT myelo, and then classify, very important to classify, suspect incomplete with retention, and decompress urgently. Aim is less than 24 hours. Do not delay unnecessarily. And then counsel the patient about all this and document it. And rehab bladder program is very essential. So what's the epidemiology of Cauda equina in the United States? Is about 1 in 100,000 per year. And typically, as I said, it's L4-5, L5-S1, and lumbar spine, especially L4-5 and L5-S1, is by far the most common region for Cauda equina syndrome lesioning. Lumbar stenosis, lumbar intervertebral disc, tumors, spinal infections, trauma, all these are even AVM can be a situation where in which can it manifest with the Cauda equina, especially if it's in the L1 and the L2 possibilities. So in the history, low back pain, unilateral or bilateral pain, asymmetrical, weakness is potential, and sensory losses, you see that, loss of reflexes will be there, bladder dysfunction, bowel dysfunction, and sexual dysfunction. Classically, motor and sensory and visceral sphincter involvement is the hallmark of not much of recovery that you can expect. Outcome depends heavily on the initial severity of the neurological sphincter deficit. Surgery is definitely helpful. There has been prolonged delays, especially with established urinary bowel incontinence and retention. So a patient coming with all this for a long time, the delaying the surgery is not going to really make him much worse, because it's ischemia has already set in and the deficit has already manifested. So is there a cutoff time? So there is, I went through a huge literature search about all this 24-hour, 48 hours, or more than 48 hours. But there is absolutely no strict rule, medically evidenced study to say that this is going to help if the visceral involvement is already occurred. So there is no cutoff line like to ensure that 24 or 48 hours you got to rush for surgery. But if there is if there is an incomplete Cauda equina, there are a lot of studies that show that if you do the surgery within 24 to 48 hours, it's much better outcome in terms of recovery. So this was anatomically, first Cauda equina was described by a French anatomist. His name is André Lawrence, and then the actual syndrome was described by Baxter in Boston. And earlier studies, there were a lot of studies have people did before, like in 1989 and all. Jonathan Hutchinson's was the first, but he did not know that it was Cauda equina. He just saw the disc herniation manifesting with paraparesis, and he was pretty perplexed with how is this happening so suddenly and so quickly with the paraparesis. But the rule of vascular involvement, ischemia, and all this was not well described by Jonathan. And then Mixter and Baird in Boston, they were the first one who published the data, and then they said then there was a lot more articles that came in the New England Journal of Medicine. Dandy also saw in 1929, he also saw some of the disc herniation manifesting with Cauda equina compression, and he treated them transdurally. He did not know that it was because of the disc, so he opened the dura, let the CSF, hernia come out, so that then the just disc mushrooms out itself, and then he took the disc out. So it was very interesting. I went through the literature search on how he did what he did, and but that's like, as we all have seen, when there's a massive disc, the thecal sac is so tense, you almost feel difficult to get into the disc space, even unless otherwise you do a wide facetectomy, a foraminotomy, and all that to get there into the disc space. So those days, of course, Dandy did not know to do all those things. Probably he was like, okay, let me just get the tension out of the thecal sac. Probably then I can approach him, which is not a bad idea, but it was a good technique that he did. This is again, I'm going through the manifestations and why the ischemia occurs, and back pain, bilateral sciatica, progressive leg weakness, sensory loss, sphincter disturbances, bladder bowel, areflexia, what we now call the Cauda Equina Syndrome. These are the classical manifestations, classical progression of the symptoms. This is the modern description: severe low back pain, sciatica, saddle anesthesia, urinary retention, fecal incontinence, leg weakness, and then the sexual dysfunction. As I said, it's less than 1 in 100,000, and now there are a lot of studies that have been published on the timing, and has anyone recovered completely neurologically with all these modern things that we do? There is recovery, but even people have seen recovery of some of these patients who have been rehabilitated up to 5 years. There is a hope that they can get back, but the visceral function is something that has been not been, even though they have rehabilitated pretty well, bladder function has suffered quite a bit in some of these complete Cauda Equina Syndrome patients. So just want you to know, because I had a patient who came in with Cauda Equina, and he sat in his house for 4 days with his symptoms, and I saw him in the ER. I told him very clearly, showing him the MRI, told him that the neurological recovery is only a hope, but I'm just giving you a chance. And I put all those things. And both the patient and the lawyer filed a lawsuit, and I'm still going through this. And the unfortunate thing is, the lawyers don't know medicine, and they act as if they know medicine. At least if they have some amount of innocence, we can teach them so that they can ask intelligent questions. But most of the times these lawyers are so arrogant and stupid, and that's where the problem comes. And then they don't want you to, they just want you to say yes or no for the questions they ask. And that's where the problem comes, that you cannot even explain to them what exactly the situation is. So finally what I decided was to make this presentation and give it to the judge. Let her decide what she wants. So that's the main idea. I came up with all the literature to tell them that, you know, I had no choice and I had nothing else to do for the patient. I've done everything maximum, and still I'm going through this. So I just wanted to share this with you guys so that you get a fair idea about both things. Thank you.
You want me to
Finish the next one too, or wait?
No, you are at the other sessions. Yeah.
You want to introduce Dr. Younis?
Younis. What do we have to do, Younis? Okay.
Business standard graduate
Yes.
adult.
Younis?
Yes. Okay, so we'll have the pleasure to introduce Dr. Manaf Younis. Actually, I did take his exam not long ago. He's a new member of our group. It's the first year that represent being part of the group. The AMS, and with the certification. So Dr. Younis is a physician with training in both medicine and public health. His work bridges clinical practice with population health, focusing on improving healthcare delivery, surgical outcomes, and access to care. He has been involved in research and educational initiatives examining health systems and clinical outcomes. Welcome.
Good morning, everyone, and thank you for joining me today. It's a privilege to speak at the American Academy of Neurological and Orthopedic Surgeons. Over the next 20 minutes, I want to take you through where we are today in the deformity care, and where the field is moving, and how we can elevate the outcomes of our patients. Now, what once was considered cosmetic or quality of life issue is now recognized as a major driver of disability. And it's not just something complementary. It's very essential to understand and to care for. Now, before we dive into the details, I want to give you a quick roadmap of where we're headed today. Adult thoracolumbar deformity is a massive and growing clinical challenge, and understanding the full landscape helps us make better decisions and for our patients. We'll start with the epidemiology and the true burden of the disease, because this is not just about curves on X-ray. It's about disability, frailty, loss of independence, and the enormous economic impact on both patients and healthcare systems. From there, we'll move into alignment concepts. Over the past decade, our understanding of sagittal balance has completely reshaped how we evaluate and treat deformity. Pelvic parameters, PI-LL mismatch, SVA, these are not just academic ideas. These they directly correlate with patient reported outcomes, and they guide our surgical planning. We'll then look at the major surgical innovations that have changed the field, from MIS deformity correction to advanced inner body technologies and navigation-assisted instrumentation. After that, we'll walk through osteotomies, which remain essential tools for fixed sagittal imbalance. Finally, we'll talk about complication reduction and future directions, including AI-driven planning, smart implants, and predictive analysis. My goal is to give you a practical, clinically grounded framework you can apply immediately in your practice. Now, when we talk about adult spinal deformity, it's important to recognize just how common and impactful this condition really is. The prevalence increases dramatically with age. By the time patients reach about their 60s and 70s, studies show that up to 60% have some degree of degenerative scoliosis or sagittal imbalance. And this is not just a radiographic finding. These patients experience real, measurable disability. Adult deformity is strongly correlated with poor scores on ODI, SF-36, and PROMIS scores, often at levels comparable to chronic heart failure or advanced arthritis. Degenerative scoliosis is by far the most common pattern we see. It's driven by asymmetric disc collapse, facet arthropathy, and progressive coronal and sagittal malalignment. But what's often underappreciated is the sagittal component, the loss of lumbar lordosis and the pelvic retroversion, the forward shifted center of gravity. These are the factors that truly drive pain, fatigue, and functional decline. From a healthcare utilization standpoint, these patients represent a significant burden. They have higher rates of opioid use, more frequent injections, more physical therapy, and more imaging. And when they do undergo surgery, the procedures are complex, source intensive, and associated with high complication rates. Understanding this burden is essential, and because it underscores why alignment-based, patient-specific treatment strategies matter. This is not just about fixing a curve, it's about restoring the quality of life. Now, when we think about adult spinal deformity, it's important to appreciate that it's fundamentally a degenerative process, not a congenital one. These patients do not start with a curve. They develop one over time as the spine ages and undergoes asymmetric wear. The first driver is usually a degenerative disc collapse, particularly at the lower lumbar levels. As the disc height narrows asymmetrically, the vertebral body begins to tilt, and the tilt becomes the seed of the coronal curve. Next, the facet joints begin to fail. They hypertrophy, they sublux, and then they lose their ability to guide motion. This leads to rotational deformity, which is why degenerative scoliosis often have a strong rotational component, even when a coronal cup angle is modest. But the real clinical impact comes from the loss of lumbar lordosis. As the spine stiffens, the disc collapse, patients lose the natural curve that keeps their center of gravity balanced over their pelvis. The body tries to compensate, first the pelvic retroversion, then with hip extension, and eventually with knee flexion. When those compensatory mechanisms fail, patients develop progressive sagittal imbalance, which is the single strongest predictor of disability. Understanding this pathophysiology is essential because it guides our surgical planning. We're not just correcting the curve, we are restoring alignment, biomechanics, and function. Now, when these patients walk into clinic, their symptoms often tell the story before the x-ray do. The most common complaint is axial back pain, usually mechanical in nature. It's the pain of asymmetric loading, facet arthropathy, and muscular fatigue. Many patients describe a deep aching discomfort that worsens throughout the day as their compensatory mechanisms start to fail. Radiculopathy is also common, especially when there is lateral listhesis or foraminal stenosis at the apex of the curve. These patients often have a very characteristic pattern, unilateral leg pain that worsens with standing and walking, sometimes alternating sides depending on posture. Another hallmark symptom is postural fatigue. Patients tell you that they can stand only for a few minutes before they feel they're falling forward or leaning to one side. This is the lived experience of sagittal and coronal imbalance. There are constantly fighting gravity, and that fight is exhausting. As the deformity progresses, patients develop functional decline, difficulty with household tasks, reduced walking tolerance, and loss of independence. Many will tell you they've stopped doing activities they love, just because they can't maintain their upright posture. Understanding this clinical picture is essential because it helps us correlate symptoms with radiographic findings and tailor our treatment strategy accordingly. Now, when evaluating adult spinal deformity, the radiographic workup is absolutely foundational. These patients require comprehensive, full-length standing evaluation, not just lumbar films. The reason is simple. Deformity is a global problem. You cannot understand the coronal or sagittal balance without seeing the entire spine, pelvis, and lower extremities in a weight-bearing position. That's why standing EOS imaging has become the gold standard in a lot of places. It gives us low-dose, full-body alignment data with exceptional clarity. We always start with AP or lateral full-length views. On AP, we assess the coronal cog angle, vertebral rotation, lateral listhesis, and pelvic obliquity. On the lateral, we evaluate sagittal vertical axis, and we evaluate the lumbar lordosis, the thoracic kyphosis, and the all-important PI-LL mismatch. These parameters correlate directly with patient-reported outcomes and guide our surgical planning. Flexion extension films are very important. They help us determine whether the deformity is flexible or fixed, which influence whether we can correct it with inner body work alone or whether we need to do some osteotomies. They also reveal dynamic instability, especially at levels where there is lateral listhesis or severe facet arthropathy. Now, when we talk about, talking about alignment parameters are the backbone of our evaluation and surgical planning. These measurements are not just abstract numbers. They directly, as I mentioned, they directly correlate with function, pain, post-operative outcomes. Now let's start with pelvic incidence. This is a fixed anatomic parameter that defines the shape of the pelvis and dictates how much lumbar lordosis a patient needs to stand upright comfortably. A high PI requires more lordosis, a low PI requires less. Next is lumbar lordosis. Key concept is that lumbar lordosis should match the PI within 10 degrees. And when the PI and LL are mismatched, patients experience forward trunk shift, compensatory pelvic retroversion, and increased energy expenditure just to maintain their posture. This mismatch is one of the strongest predictors of disability. Sagittal vertical axis, the SVA, is another critical parameter. It measures how far forward the C7 plumb line falls relative to the sacrum. SVA greater than 5 centimeters is associated with significant functional decline. Finally, the pelvic tilt reflects how much the pelvis is rotating backwards to compensate for sagittal imbalance. A high pelvic tilt means the patient is working hard to stay upright, to keeping his center of gravity above his pelvis. Now, when we shift our focus to coronal alignment, The first thing we think about is Cobb angle. It's the classic measurement, that we usually do. But in adult deformity, the Cobb angle alone rarely tells the full story. A 30-degree degenerative curve can be far more symptomatic than a 50 degrees adolescent curve because the underlying degeneration, stenosis, and imbalance. One of the most important considerations is curve flexibility. Flexible curves often respond well to indirect correction through interbody work and strategic releases. In contrast, stiff curves with bridging osteophytes and autofusion may require aggressive techniques, including osteotomies. Now, another thing is lateral listhesis is another hallmark of degenerative scoliosis. Even few millimeters of translation can cause significant foraminal stenosis and therefore radiculopathy. Pelvic obliquity is frequently overlooked, whether it is due to limb-length discrepancy or as a compensatory mechanism to the scoliosis. Finally, the global coronal balance, which is the relationship between the C7 and the central sacral vertical line, it helps us to determine whether the patient is leaning to one side. Coronal imbalance can be just as disabling as sagittal imbalance, especially when combined with leg-length discrepancy or hip pathology. Now, talking more about the sagittal alignments, it's the single most important concept to understand. It is the strongest predictor of disability as proven with evidence and research. The cornerstone of sagittal evaluation is the PI-LL mismatch. Pelvic incidence is as I explained, is the fixed anatomic parameter. Lumbar lordosis must match it within about 10 degrees of for the patient to stand up comfortably. When the lumbar lordosis is insufficient due to disc collapse or facet degeneration or prior fusion, the patient shifts forward. This leads to pelvic retroversion. The pelvis rotates backwards to bring the torso over the hips. Pelvic tilt increases, sacral slope decreases, and the patient begins to burn energy just to maintain posture. When pelvic compensation is exhausted, the patient develops a positive sagittal balance, measured with the sagittal vertical axis. Even few centimeters forward can dramatically increase muscular demand and fatigue. The body then recruits additional compensatory mechanisms, hip extension, thoracic hypokyphosis, and eventually knee flexion. These compensations are not sustainable. Patients often describe profound fatigue, difficulty standing upright, and reduced walking tolerance. Understanding all these sagittal alignment concepts is essential because it directly informs our surgical goals. We're not just correcting the curve, we are restoring function, efficient, energy-conserving posture. Talking about surgical indications in adult deformity, should we always fix the curve? Should we, when do we consider this? Now, it's usually underestimated. We are operating on patients whose quality of life has declined despite appropriate conservative care. The strongest indication for surgery is progressive sagittal imbalance, because once the compensatory mechanisms fail, patients simply cannot maintain an upright posture. They describe the fatigue, difficulty standing, etc. Number two is intractable pain. It's another major driver, whether mechanical back pain from all the arthritis and the arthropathy, disc collapse, or it's radicular. Another thing is neurological deficit, progressive weakness, severe neurogenic claudication are also strong indications. We also consider functional decline, as we mentioned, reduced walking, loss of independence, inability to perform daily life activities. Now, when conservative care has failed, the patient's symptoms and radiographic parameters align with correctable deformity patterns. The goal is not just to fix alignment, is to restore function. Now, different classification systems, just briefly, quickly, I'll go over them. There is the Schwab classification, provides simple coronal framework, thoracic, thoracolumbar, and double major curve types. It helps us understand the primary deformity driver and guides fusion level selection. There is the SRS, Schwab modifiers. They also they add the sagittal dimensions, which is the most important predictor of disability. There are 3 modifiers: PI-LL mismatch, sagittal vertical axis, and the pelvic tilt. They quantify the severity of sagittal imbalance. Patients with severe modifiers, PI-LL mismatch of more than 20 degrees, SVA more than 9 centimeters, pelvic tilt more than 30 degrees, they consistently have worse outcomes and more likely to benefit from surgical correction. And lastly, the GAP score, the Global Alignment and Proportion Score, is a more recent system, evaluates the mechanical alignment relative to age-adjusted targets, which is the new concept that the PI-LL mismatch is not uniform for everybody. There are some age-adjusted alignment targets. It incorporates the pelvic incidence, lordosis distribution, relative pelvic version, and the global tilt. Higher GAP scores correlate with increased risk of mechanical complications, such as rod fracture and PJK. Finally, Rasuli profiles describe a natural sagittal shape of the spine based on pelvic incidence and lumbar lordosis distribution. Understanding all these classifications help us understand the alignment goal, avoid overcorrection, and tailor the alignment goals relative to their native anatomy. Now, let's talk about alignment goals. They are, as I mentioned, they are the cornerstone of adult deformity correction. The most powerful is PI-LL mismatch. It should be under 10 degrees. In general, as I mentioned, there are age-adjusted goals. This restores efficient posture, reduces muscular compensation, and improves energy expenditure. Number 2 is the sagittal vertical axis. The goal is to bring it down to less than 5 centimeters, which correlates with improved pain, walking tolerance, and patient satisfaction. However, we must avoid overcorrection, especially in older osteoporotic patients, where slightly positive axis, vertical axis, may be more physiologic and would prevent PJK. Pelvic tilt is a marker of compensation. The target is less than 20 degrees. That indicates that the pelvis is no longer retroverting to maintain balance. When the pelvic tilt remains elevated post-operatively, patients often continue to experience fatigue and functional limitations. Modern planning emphasizes age-adjusted alignments. As an example, recognizing that a 75-year-old does not require the same lordosis as a 40-year-old. These targets reduce the risk of junctional failure by avoiding overcorrection. Finally, restoring the physiologic lordosis distribution, which is very important and usually overlooked, with the majority of lordosis being between L4 to S1. It is critical. Even if the total lordosis is correct, a maldistributed curve can still lead to mechanical complications. Alignment goals are not just radiographic metrics. They are functional targets that directly influence quality of life. Now, minimally invasive deformity correction has become a major evolution in adult spinal deformity, offering meaningful reduction in morbidity while still achieving powerful alignment correction in the right patient population. The foundation of the MIS deformity correction is multi-level lateral interbody fusion, typically a lateral or oblique interbody fusion. These approaches allow us to restore disc height, correct coronal tilt, and achieve indirect decompression across multiple levels with minimal soft tissue and muscle disruption. The ability to place hyperlordotic cages at key levels gives MIS strategies real sagittal power. When used thoughtfully, lateral interbodies can restore 20 to 30 degrees of lumbar lordosis across the lumbar spine without the need for osteotomies in flexible curves. Now, percutaneous instrumentation complements this approach by minimizing muscle dissection and reducing the post-operative pain. Modern navigation dramatically and robotics have dramatically improved the accuracy and efficiency of percutaneous screw placement. MIS deformity correction is best suited for flexible curves, and hence the flexion extension images, lateral bending images, all that evaluation if the curve is flexible or fixed. Now, modern interbody technologies have dramatically expanded our ability to restore alignment while minimizing the morbidity. Expandable cages allow controlled restoration of disc height and foraminal dimensions through small working corridor. They are particularly useful in MIS approaches where insertion height is limited. Expandable designs also allow intraoperative fine-tuning of segmental lordosis, which can meaningfully contribute to global alignment correction. Hyperlordotic cages provide powerful sagittal correction, especially at L4-5 and L5-S1. These implants, as I mentioned, can give 20 to 30 degrees built-in lordosis, which can restore the lumbar curvature without requiring osteotomies. They are especially valuable with PI-LL mismatch or flat back deformity. Now, porous titanium implants represent the next generation of interbody implants. Their 3D printed lattice structure mimics cancellous bone, promoting osseointegration and improving fusion rates. The roughened surface enhances mechanical stability, and their porous architecture allows vascular and cellular ingrowth. Now, osteotomies, as we always know, several types of osteotomies, and they are used with fixed deformities that are not flexible. Of course, the simplest is the Smith-Peterson osteotomy, and then there is the Ponti osteotomy, where you just do the facetectomies with the just the ligament of Plano. And of course, as you take more bone, there is the pedicle subtraction osteotomy, and there is the most complex is the vertebral column resection, which involves the complete vertebral removal. Now, when do we do those? As I said, when the curve is fixed, rigid, or there is a focal kyphosis at some point. Now, in the next few slides, I'll highlight where the spine surgery is heading, from AI-driven planning and robotics to smart implants, biologic enhancements, and more personalized alignment strategies. These innovations are reshaping how we plan, execute, and monitor deformity correction. And together, they represent the next evolution of spine care. Now, artificial intelligence is poised to fundamentally reshape how we plan deformity surgery. Today, alignment targets are based on formulas and surgeon judgment. But AI-driven platforms are beginning to analyze thousands of deformity cases to predict ideal post-operative alignment for each individual patient, taking into account age, pelvic incidence, flexibility, bone density, and compensatory patterns. These systems can also generate personalized correction plans, suggesting the optimal combination of inner body levels, cage angles, osteotomy types, and rod contouring strategies. Early models have already been outperforming traditional planning in predicting the post-operative vertical axis and the PI-LO mismatch. Another major advance is risk modeling. AI can identify patients with higher risk of PJK, a rod fracture, or pseudoarthrosis in the construct design, bone quality, and alignment targets. Smart implants represent one of the most exciting frontiers in spine surgery. The next generation of pedicle screws will incorporate microsensors capable of measuring real-time mechanical load across the construct. This allows us to detect early signs of rod fatigue or screw loosening long before they become clinically apparent. Another emerging technology is wireless fusion monitoring. Sensors embedded in inner body cages or rods can track micromotion at the fusion site, providing objective data on fusion progression. Imagine being able to confirm fusion without relying on a CT scan. That's where the field is heading. Now, with robotics and navigation, those make screw placement simple and safe, and they guide us into full construct orchestration system. Now, with the predictive rod contouring, which instead of manually bending the rods, is also, we are heading there, and as I mentioned, integrated alignment feedback intraoperatively, that would help us reduce variability and make this process reproducible. Biologic, different types of biologic. Now it's not only mechanical, but biologic fusion. That's what we should also put in mind. Now, avoiding mechanical complications, the first step is by optimizing bone quality and that will, of course, decrease the complications of PJK, rod fracture, or screw loosening. Of course, by preoperative optimization of the bone health with evaluation of the bone density, vitamin D, anabolic hormones, therapy that would improve the construct durability. The upper instrumented vertebra and the lower instrumented vertebra selection is very important, and that is part of our planning. Strong pelvic fixation is crucial, and of course, as I mentioned, age-adjusted goals to avoid overcorrection. Rod reinforcement and accessory rods, that should always be considered. Now, junctional protection strategies, there are different ways to do that. Now, in conclusion, as we wrap up, I want to bring the entire discussion back to a single central theme. Alignment drives outcomes. No matter how advanced our implants become, no matter how refined our techniques are, the patients who do best are the ones whose sagittal and coronal balance is restored in a thoughtful, individualized way. And thank you very much.
Thank you.
So you've got a lot of strategies on your planning, but where does age come into this? Minimum age, maximum age?
So age is just a number. It's about the physiologic status of the patient. So about comorbidities, about their bone health. That all comes into the picture. Now, if your question was what are our goals, that's also part of the goal age-adjusted targets. So again, there is a table where the PI-LL mismatch changes with age. So generally, we are classically taught that it should be not more than 10 degrees. However, the evidence have showed that, for example, over 70 or over 80, you can accept 30 degrees of. The whole idea is to look at the alignment as a full patient, like holistically, not just look at the lumbar spine or just at that level, because a lot of times, and I've seen that very frequently, the patient cannot stand up straight, and you confuse it with neurogenic claudication. You think that's, if I just go there and decompress that level, he's going to be fine. But no, when you look at him, they are bending forward, and of course we think that's normal aging, but it's not.
Okay.
Thank you.
Excellent.